Yeah, you can hear me?
Yes, sir. Here you can hear you, sir.
Good afternoon, sir.
Just
Manjunath
hold
here.
on. Hi.
How are you, sir?
All good. How are you, Manjunath? You left the hospital?
No, sir. I left Apollo. I joined Yashoda.
You left Apollo, Manjunath?
Yes, sir. Yes, sir. I joined
Yes, sir.
Yashoda Hospital, sir.
Good place?
Yes, a good place, sir.
Yeah.
How are you doing, sir?
Chalo. Roshan is there. Roshan Shetty, Bangalore.
Hi, Shishir bhai. How are
Hi.
you?
From a
Nice
clean
to see you
shaven,
on
looks
this
like a
platform.
gentleman. Huh?
Nice to see you on this platform.
You look like
बोल
that.
आर्या बोल
Yeah.
बोल आर्या
Thanks to
निक
Samir.
निक 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 निक
Yeah, he told me. So I said, no better person to, hold this meeting.
पशुपति
So Manjunath is from
I
Hyderabad. He,
yeah allow
Okay,
camera
Manjunath does a lot
nothing is
of
happening
thoracic work, does a lot of robotic
okay,
work.
great.
How was your trip to Italy
Palani
this
Palani
time? You were there, na Manjunath?
you
Sir?
use Google Chrome okay
Hello, sir. Trip to?
okay
You had gone to train with the robotic surgeon, right?
Yeah, sir. We
so
went
I
for
shut down I'll
Portugal
leave and
last
again
month.
come back but then from where I should come okay
I'll
I'll
just join
get
you in
again
2 minutes.
WhatsApp again no
Tell me, I can show. How do I
but
show?
I do again in
If
Google
I have to
Chrome
show
no
my slide presentation,
okay
Hmm.
how,
There's a share screen option, no? Next to the camera icon.
share
Hi,
screen.
Dr.
Yeah, so
Ramkaran.
I allow to share screen. Hi.
Yeah.
Good afternoon, sir. Good afternoon, sir.
Ramkaran is from AIMS Jodhpur.
Oh,
He does a lot of the
so
thoracic
everybody
VATs
can
and
see
everything.
this.
Yeah, I can see.
Oh, great. Just all of you are very well versed with thymectomy, so please feel free to comment because this is an absolute non-edited video which we have taken.
Okay.
Can you see the screen?
Yeah, we can see the
Yes,
screen.
we can see the screen. We are able to see this.
Exactly at sharp 3. Yeah. Yeah.
Can I
Exactly
just
at sharp
can
3
you
we'll
see the
start.
CT scan?
Yes,
Can you
yes.
see the CT scan? Can I
Yes,
just run
yes.
the video?
Sure. It's running.
Yeah. So at any
Yeah.
time, look, because this is unedited, because at any time you want me to, take it fast forward or something, just let me know. I can do that.
Okay.
Because,
You can also choose.
timers, I feel
You
1 hour
can.
is too much.
No,
Yeah, I
you can,
can do that because
you
I feel 1
yourself
hour
can
is
edit
too
it.
much.
Yeah.
No, Samir told just show them the unedited version because that is what you need. I said, okay, great.
Correct. Generally, on this
Because,
program, what we do is, Shishir, is we ask some international faculty and national faculty show some live, if possible, or else we'll do virtual live. So it is unedited,
अभी
basically.
किधर से होने लगा
yeah. Yeah, because they will know the problems that we face sometimes. Edited ones look
Correct, correct.
all of them look good. Yeah,
Yeah.
done. All right, so I'll wait for you.
Yeah, Shishir. One thing is only the moderators and the will be on this platform. This will be relayed
Uh,
on to a GEM Televersity platform where the delegates will be there. So if
all
they
right.
have any questions, we'll put it on the platform there, which will be transmitted here. If you look at the right hand corner of your screen, there
No,
is
I won't
audience
be able to
questions.
see because my video is showing
I
only
know,
the
I know. I'm
slide.
talking to the moderators. Yeah, with regards to moderators, they can take up that questions and present it to you.
Sure, sir. Sure, we'll do that.
All right.
Yeah.
Sir, just one thing I want to ask. Can we stop
Yeah.
the video and ask some questions as moderators, or how is it? We want to continue to flow the video and then at the end we'll ask questions.
No, the
Look,
presenter, when him to pause, he can
look,
pause.
this video is a very slow moving video, so we can generally chat about your life also if you want.
Okay. So we can talk about the step at the same time. Not a problem. Okay.
Yeah,
Yeah,
yeah.
there is, Thymus has very few steps. So,
Yes, sir. Yeah, definitely so.
yeah. Hello.
Hello, Dr. Shetty.
Yeah.
Yeah, hi, Shishir. Hi, Sanjay here. Bolte.
Okay, that was supposed to be to Shishir, I suppose, not to me. But
Oh,
there are
okay.
two Shishir here.
Oh, okay. I'm so sorry, but
No problem, Dr.
surgery.
Sanjay.
Yeah,
Yeah.
so I've been on surgery. So because I couldn't adjust the time, but I'll be more or less a very student for Shishir Shetty,
Okay.
and I'll listen to whatever is thing and try to attend on time.
Great.
Yes, and I'll definitely give inputs or ask questions whenever it's required. So my video will be off, but then I'll be online. Yeah.
Okay, sure.
Okay. Yes. Thank you so much.
Samir, you're there?
Yeah, my laptop has some issues. I'm on my mobile now.
Okay. I think there is a network issue on your end also. The voice is breaking at times.
No, because I'm on mobile now. That after my laptop working, suddenly the camera is not working. Otherwise, I'm okay.
Okay.
So I'm trying to
Uh,
connect again.
so the sequence of events, Samir, will be that you'll welcome everyone. I think Dr.
Yes.
Kalpesh, the president, will join later on. He will not be there.
Yes.
So
Okay.
I'll give the welcome address.
Huh.
Once I finish that, you can talk about the upcoming programs of Amasi and Smart Center. Okay,
Okay.
I'll ask Pashupati to project the slides. You can read it out, and
Yes.
then you introduce the speaker and the moderators.
No problem.
Yeah, brief CV if you want to tell, you can tell, and then
Yeah.
ask Shishir over. Okay.
Yeah. So 5 minutes
Once
to go.
once the end of the program, every question and answer is sorted out, then you can actually give the vote of thanks. Okay.
Yeah. Sure.
Any next month program का कुछ idea है?
I have again spoken to those 2-3 people. One is Anuvang. I have spoken for per oral transvestibular thyroidectomy. That is one.
Okay.
One person from Germany I have spoken. He does 2 ports inguinal hernia,
Okay.
laparoscopic. So they have not yet. They don't finalize only. Last moment they don't pick up the phone itself. That's the issue.
Okay. So I think it's better now itself you approach and then take a
Yeah.
acceptance.
I'm after them. So is it okay if I don't show my camera like this, because other side I can see everything. Now you're seeing from other side.
Okay.
2 devices logged in.
Uh-huh.
Because I have to call other. Ramkaran is there. Very good.
Good evening, Regis sir,
Good evening,
Shetty sir.
Ramkaran. Good evening.
As
Devanke.
also thank Mary Samir.
Yeah, sure. We'll start.
Yeah.
We'll start with Meril only. We'll ask them that they are hosting us. So we'll thank them and then we'll go ahead.
Yeah.
Right. Yes, sir.
Exactly 2:59 you give the count.
Yes.
so that Pashupati and Venkatachalam sir can actually transmit it to the Teleuniversity.
Sir, 257, sir. 3 English mode.
257.
Uh,
Now it is 257. 259 we can.
okay,
Yeah.
sir.
Okay.
India and Bali.
Samir bhai,
Yes, boss.
Shishir is a multifaceted personality, huh?
He's a big man. Somehow I try.
Big-
He just took me 1 minute. I asked him and he said yes, I will do it. So I told him
Yeah,
please don't edit because otherwise it will be some 5 6 minutes job for him. So I said we at least want for one at least an hour. So then he said okay, I'll edit
correct.
only what is living. Shishir is the fastest oncosurgeon whom I know. Maybe finishes
Mm.
mastectomies in 12 13 minutes. That's what his record is. I think we are 259.
Sir, 259.
Yeah.
Samir, I had an opportunity to work with Shishir for some time. Shishir, it was a great opportunity in probably 2002, 2003. Right, Shishir? Yeah. Since then, he is being we've been meeting in conferences and I'm following him since then. Before, I think Tata's days.
Mm.
Tata days was so good. Yeah,
Thank you, Shishir.
really, Tata days were amazing. Best times we had. I think there was no pressure from
I think it's
anybody.
3
Just
o'clock.
work.
Pashupati.
Sir, 10
Yeah.
seconds. 10 seconds. 10 seconds. Okay, sir. 3
Okay.
seconds count. 3.
Give a countdown, Samir.
Uh,
Yeah. Uh, Good afternoon, everyone. On behalf of Amasi Lens, I am Dr. Samiriga. I'd like to welcome you all for yet another session of live surgery oblique minimal edited video. I'll request our Honorable Secretary, Dr. Roshan Shetty, to welcome you all. Over to you, Dr. Roshan.
Thank you, Samir. You have been conducting this for last couple of meetings. Actually, Samir is our joint secretary as well as a convener for Ramasi Lens program, which is basically a virtual live or a live surgery program. It's been successfully running for last 1.5 years. And it is a privilege to have Dr. Shishir Shetty, who's an oncosurgeon, also a lab and robotic surgeon in Mumbai. Thank you, Shishir, for accepting our invitation. I'd also like to acknowledge the moderators for today, Dr. Manjunath Bale, Dr. Ramkaran Chaudhary, Dr. Sanjay Kolte for this program. And I welcome all the delegates. Hope to have a
Thank you.
wonderful interactive session.
Thank you for the
And over to Samir.
Uh, at the outset, I'd like to thank Merrill for giving us the opportunity where they are contributors to have this monthly program. Not even this, other Amasi programs also. Pashupati, can you put up the list of our upcoming events so that people get appraised about it? So here are our upcoming events. We have a safe laparoscopic cholecystectomy program on 27th October. That is Sunday at Hubli. Then on 8th and 8th to 10th of November, we have MMS program on HPB, which is a super specialty program, followed by Necasicon, which will be held in March 2025 from 29th to 30th. And we have FMAS program, which will be run at Nayar Hospital from 5th to 7th of December at Nayar Dental College. Uh, so today we have none other than Dr. Shishir Shetty, who is a professor and head of surgical oncology at DY Patil, a proficient uh, oncosurgeon, oncosurgeon with open surgeries, but laparoscopy and robotic surgery. We have a good panel of moderators. So today Shishir will be showing edited video of thoracoscopic thymectomy. We have four eminent surgeons who have good specialty in thoracoscopic surgery. Dr. Ramkaran, who is a professor at AIMS Jodhpur. Dr. Priya Ishpunyani, who is a thoracoscopic surgeon and visits many corporate sector in Mumbai. Dr. Sanjay Kolte, who is a proficient thoracoscopic surgeon at Sahyadri Group of Hospitals at Pune. And Dr. Manjunath Bal, who is a thoracoscopic surgeon who does only thoracoscopic surgery at Yashoda Group of Hospitals at Hyderabad. So may I request moderators to take over and request Dr. Shishir Shetty to start his session and update us.
Thank you, Samir, for this nice introduction. Should I start now?
Yeah,
Yes,
go
yes,
ahead.
please.
Yes. So I think since thoracoscopy came, thymic surgery has become quite easy because and the number of cases also have increased. Probably I do not know why. Is it because of more surgeons or because the incidence has increased? That is yet to be determined. Just can you hear me? Hello.
You are audible.
Ye-
Yes,
You are
yes,
Yeah.
yes, yes.
So just this is around a week, 10 days back. This young chap, 22-year-old guy, he came to me with complaints of cough. And cough, he went for investigation, got an X-ray, CT scan done, and there was a thymoma which was sitting there on the left side. They got a biopsy thinking that it may be lymphoma because at that age group it is pretty common. With no symptoms, just occasional cough. And I think that the cough may have been incidental. So this was detected, and then we planned his surgery. So this is a CT scan picture. Can you see the uh, nice, good thymoma which is sitting over the subclavian artery there? Yeah. So I start the video. So what we did was we took three ports. The first port we did in the fifth intercostal in the mid axillary line, and the second port was along the same in the mid clavicular line. All right. So as soon as we put in the port, you can see this lung down here, and this is the thymus gland. This is on the left side. Please understand that left side the space is a little bit constrained. So you have to work around things. This is the pericardium sitting there, and we put in our second rib space. We put in another port there. So so they were all 2 10 mm ports and one 5 mm port. All right. So this is the absolute basic to which we started. And
can you
so
something
please, and so
patients?
just let me tell you that this is not an edited video. This is the video as I have taken it. So you'll find a lot of lag because we were adjusting the camera, all this. Uh, I'll just take you through that a little fast forward that place where we were cleaning the place. Yeah. See this? Yeah. A little bit of fogging there. So yeah.
Sir, can you elaborate something about the position of the patient? This is very important in these days.
What this was, a patient was in supine position, uh, with the hand going backwards below the head. That's it. Means no other special position we gave. It's a very pretty straightforward. Patient was more towards the left side of the bed, a little bit exactly on the border, so that your camera port, which is near the mid axillary line, we don't have an issue. And I
Yeah,
raised the
your
table.
yes, yes. Dr. Shishir, your right side working port then comes in which space? Third space?
So it is in the second space.
Huh. So sometimes what I have found is that probably the when we go from the left side, it
Yeah.
hits your axilla or arm whenever you are doing it
Yes.
with this thing. So do you also
Yeah,
feel
yeah,
the
yeah.
same that the
Yes,
yeah,
in
yeah.
fact,
Huh?
I will tell you whether both robotic as well as this robotic. In
Correct,
fact,
correct.
we
Huh.
have some problems when the arm hits the robotic arm will hit the hand or the bed, or so that becomes a problem. The one way is to just take the hand and put it right below the head, or hang it over the head. So that becomes an easier way to go about it.
Exactly. Even that. Yeah. Thank you.
Yeah.
Yeah.
So this is your second space where I'm making a port there. You'll find this extremely slow because I have just, yeah.
Sir, did you investigate your patient for anticholinergics antibodies? Your patient had
All were,
thymus.
everything was
So
normal.
my query is sometimes you just find some thymoma. Patient can have subclinical myasthenia. So
Agreed,
did you
agreed. No, we investigated the patient, but we didn't find anything. There was everything was normal. So the this boy was 22-year-old. Okay, so normally the camera port is in the mid axillary line, but generally, we see how the tumor is placed, and we can change the camera to wherever you can place it and get a better view. Uh, so what we did was we put the camera in the mid clavicular line and used the axillary for operating. Put my harmonic from there. It gave me a better view and perspective. Yeah, so that's my. So this is initially when the, yeah, there are some adhesions between the thymus and the lung. You can see I've been trying to struggle to get there. Please go on, comment. This is absolutely unedited, so you can give your expert comments on this.
So, sir, Dr. Priya here. So, did this
Hi.
distance give you a trouble, sir? I mean, this
It
close
does. It
distance of the
does.
port.
It does.
So,
It
would a
does. But on the left side, we don't have much options. I
sir,
keep on. Yes.
sir any particular reason for choice of these both working ports? You said 10 mm. You could have chosen one of them to be 5 mm. Any
So the right side I took, right one was a 5 mm. The other two as a 10 mm.
okay, okay.
You can see I'm separating the lung tissue here. So a little closely adhered here. Can you see the pulmonary vein there?
It's
Hello?
visible, sir.
Yeah.
Visible, sir.
It's
Visible.
quite visible. Yeah. So and the thymus is pretty close and down there. You can see that. This the only two things here: the nerve and the vessel that you have to be scared of. So when I saw that big vein there, I thought, let me go up and start dissecting from above downwards. So I went up and down, going all over and clearing it out. So this is at the root of the neck.
Sir, do you start from like do you have a fixed approach of top to bottom or bottom to top? Like when you start doing a thymoma, do you go from like do you feel that
Whatever I
if you go
look, I'll
from
tell you
top to
whatever
bottom,
is
does it drop down? Does it drop
no
down and you
whatever
feel the lag? Or,
whatever is comfortable. Uh,
okay, because sometimes I
if
feel
you're
that when I
com-
do it top to bottom, it like sort of obscures my vision. It feels as if it's like coming and
yeah,
obscuring my vision.
I know what you're talking about. It means sometimes it can
It
go
is
on
sometimes really irritates when it's
rotating
big.
there. Yeah, it can
Yeah,
go
it
on
just keeps
rotating.
like.
Yeah,
Uh,
but whatever suits you, you look at the thymoma, how big it is, and whichever gives you
right.
the best option. Uh, I saw the pulmonary vein down. I said, let me start from above, but eventually I went down. So I just dissected from top.
Okay, okay.
Yeah, just show you this. Just took it a little ahead. Then I was comfortable because upstairs there was nothing much to be done. The only thing is probably the the thymic veins that come there. So went on dissecting this. You see, one of the reasons right side is pretty comfortable. Left side, you see me a little struggling because I think my port was pretty close. So yeah, I
Yeah, that's
struggled
what
a
I
little
felt. So
bit there.
close.
Yeah,
Like,
yeah. But then you can't help it, I suppose. Is there
true,
anybody in the anybody who wants to say something different? I would be glad to inculcate that. But so the plane looks pretty good here.
Sir, about the choice of the energy device, you have taken this harmonic.
Harmonic. I have taken a harmonic.
Do you use Ligasure also at the some stage of dissection, or is you always work with
No, I have the only either harmonic or I take a scapula which can help me, or even a hook is pretty good. Uh, because it was
because
close, so I just picked up the harmonic. I like this harmonic a little bit. And
uh, but we have to be out of this hot blood. The hot blood, a beginner should be aware that you are near the great vessels. You have to be very careful while using harmonic, especially.
I know. Anyway, what is interesting is this harmonic which I'm using. This is a new one which I bought it. It's a interesting one because this is a pretty portable stuff from Merrill. Uh, you can carry it around wherever. It comes in a small what do you call a small plastic bag. You can fit it except the arm. Very interesting. Merrill has got this, so I was very interested to use this.
but I second you, sir. I mean, I am also more comfortable with harmonic. Somehow, ligature and me don't gel. In most of the cases, harmonic is somewhat, I think, second hand of ours.
Huh. Yeah. But a scapula
Sir,
or a hook is good
I
enough.
no, actually, sir, even for me, sir, ligashore is like when I use the
Sorry, sorry.
ligashore.
Is it?
Sorry, sir, can you hear me?
Yeah, yeah, yeah. So what you can do is, if you are worried about the ligashore, you can keep the hot plate upstairs, so that you do
Yes,
not.
yes, yes.
You see the struggle because I am struggling for space there. Huh?
Yeah, and this kind of
What
harmonic,
if
which
you had
is
taken
somewhere
this?
is a better, yeah, for dissection
What if
as
you
well.
had taken this port?
Yeah.
What if you had taken this port little more? If you had taken the entire ports to two space or one space below, sir, like the camera port one space below, or like all the ports one space below, would it have helped, sir? Or if you had taken
Uh,
a sub-deferred in this patient, would it have helped, sir?
Fifth intercostal. Sometimes what happened on the left hand side is there will be a pressure onto the heart with your instrument.
Right?
You can put pressure on that. That's the only thing that I would think that can happen. But whatever suits you. Uh,
Yeah.
one good thing about thoracoscopy is that you can just put in and see whether
Yes.
it helps you. Yeah. Unlike a robot where the docking can be a problem. Yeah. Uh, Manjunath was saying something about harmonic.
Sir.
Yeah.
So whenever I use ligation, the plane is lost, sir, somehow.
Is it?
Yeah.
The the plane of dissection becomes like it fuses together. We actually lose the plane when I use a ligation. I'm more comfortable with harmonic or ultrasonic device.
Same.
Uh-huh. I thought the best planes you get with a hook, but anyway, I wanted to try
Totally,
Yeah,
sir.
that
it is.
Totally.
harmonic.
That is
Both can
definitely
work.
That
the yes, sir.
Yeah, it can be very dangerous, but I feel the best plane, especially in a thymus, you get with the hook. And even when you're doing a robotic, you use a. Uh, uh, so Nikhil is assisting me for this case. I don't know whether you know Nikhil. Nikhil, thoracic surgeon. Who? Yeah,
Yes, yes, sir. We all know, sir.
yeah.
Sir, I raised the question of harmonic because I was operating once harmonic around 8 centimeters thymo mass. And
Huh.
I
So,
raised harmonic. And I
yeah. So what has happened is the dissection upstairs is done. So as you were telling me that the tumor can actually hang down and create a problem. This is exactly what has happened. Can you see this? Yeah.
Yeah,
So this is your
that really
pulmonary. This is
sometimes
yeah,
creates a
yeah. So this is your pulmonary vein. I hope you can see the arrow here. So I had to dissect a little above that, and I think the phrenic was somewhere around here. Yeah, can you see this? Can you see this? It's pretty close. Huh? Yeah. Can you follow my arrow? It's along this plane. Yeah. So I went about. Yeah. Yeah. So you try all sorts of things to hold the timer. Sometimes it slips away. Small tricks. I use pressure. I sometimes use a gauze piece and just shove the gauze piece inside and do this. Yeah. This is sometimes a little tricky because when you cannot hold the tissue. Like if the thymus is falling down, then this becomes quite a problematic thing. So lesson learned. Try to go from below above. You'll be happy.
Sir, have you operated any
Yeah.
patients where they have received preoperative chemotherapy and radiotherapy?
No. Unfortunately, I have not yet. Thymus can be pretty bad. Huh?
Yes, sir. Yes, sir. Especially post
Uh,
chemo RT, the patients they have very bad additions to the phenomenon. So
very bad one. Yeah.
yes, yes, sir. Agreed,
So
sir. Yes.
I have, frankly speaking, I keep hearing, reading about good response to chemo, but thymic cancers are bad.
Yes, sir.
Post chemo, they are pretty bad in the sense most of them may not respond.
Yes, sir. And what we have also seen is, sir, most of the patients, their size may come down a bit, but the kind of necrosis we have,
Yeah,
the tumor part and the necrosis is the tumor component is more than the necrosis in these patients. So we
correct.
have like
So the
60% still tumor, very, very poor.
responses are not that great. So if you
Not great,
think
sir.
that you can get away, it is difficult.
Yes, sir.
Yeah, this looks pretty stuck, doesn't it? Can you see that from down here?
Yes, sir. Yes. Yes,
Yeah,
sir.
it looks pretty stuck, but I actually got a nice plane. It was only in a small area, uh, so I had to struggle a little bit there. I was a little worried about the phrenic that I will end up injuring. Can you see that phrenic down here, going here? So once I got that out of my way, then I think that solved most of my problem. Showing unedited videos are a little scary, ne? Yeah.
Again,
Can you
sir,
see this small area which showed a little bit of adhesion to the pericardium, but then I found a plane here. Huh?
okay, sir.
You
Sir,
can
one
see
of the
that?
question
Yeah.
is, yes. So, for example, if the phrenic is involved,
Huh.
are you like, do you sacrifice it
I
on if it's
do.
like, for
I do.
example, yes, sir. Unilateral is fine, sir. If there's a large
Yeah, yeah,
thymoma with
yeah. I
balancing
do.
involvement, yes, sir.
Yeah.
I think it depends. For me, it depends on what pathology it is, right? If it's like a benign pathology, you can maybe think of
We can
not
separate
sacrificing.
it nicely. Yeah.
If it is like, if it's like a malignant pathology, yes, you definitely sacrifice it to slice. But if it's
Yeah.
a
Yeah.
benign thing,
So,
myolipoma, one of those, you can just save it.
so this was the diagnosis. Can you see the plane that I got now? Just below
Yeah,
that.
that's a very nice thing.
Look, yeah, yeah. Initially, it looked tough. I thought, in a young patient, it may be carcinoma. Although, sometimes the histopathology post-op can be different from the needle biopsy. But then I got this nice plane here. Yeah. I was lucky to have a good team. Nikhil is a good thoracic surgeon trained, so he's there for all my cases. Hello. Yeah. Now, one more thing I wanted to tell you that sometimes the fear that you may be ligating some, anything which looks blue in the chest, you feel it is a vein. Huh?
Exactly, and as you know, that problem, as we all are scared of the only unknown twin,
Yeah.
probably yes,
So,
and everything is so
so,
slow in that.
so yeah. So now, after you have done a bit of dissection and your pulmonary vein is free, your phrenic nerve is free, and now the only fear is, of course, the brachiocephalic, which is upstairs. Uh, or any other vein, because suddenly if you hit a vein you might end up with a small bleeder, so we don't want that. uh, so you have to be a little bit careful. I'll show you some stupidity which I did here. It's interesting. Huh? If you can point it out, I would be glad. It will tell me that all of you are really watching. Yeah, so the upstairs I have cleared, down I have cleared, but anyway, there's a little aspect about it. Yeah. Yeah, it's a good plane, huh? Very nice plane that I've got. Yeah, on the right side, you got a lot of space, a lot of independence to do a lot of things. Left side, yeah, little bit of issues. Manjunath, you would like to do robotic for all these cases, or you want to do laparoscopy for these cases? Hello.
Sir, I would like to prefer with the robot. Definitely up to 6 centimeters should
I
be doable
Yeah, yeah,
with
yeah.
these planes.
Portal. He'll do
The
UV portal
the
robot.
Yeah, the robot will give you that flexibility of that flexibility which you will not get. You see me struggling here, uh, uh, because you cannot. It doesn't have the. Uh, you cannot twist your instrument. The flexibility which is not there. But anyway, it's a cheaper option.
Your approach in this case is from left side. Obviously, the mass is on left side. So you are always
Yeah.
operating from left side, or it's combined. How your approach?
So sometimes you if you sometimes it is on both sides. So that is the time I will do both. In the sense, I will start with the right. Once I'm free of the SVC and the superior, then I will go to the uh, left side and do it. It becomes easier if I'm doing VATs.
Sub-default approach, sir.
Huh?
Are you doing this with the sub-default approach also? Can you explain your
No,
experience?
no, I have not. I have seen other people do it. I have not done. Yeah,
I think Dr. Manju
that
is doing. He could highlight something about sub-default
yeah.
approach.
So I got the nerve out of the way. It's sort of clear now. Just small striations that I'm trying to clear. I think we are through with it. Nothing much. Now, can you see this area?
Hmm.
I don't know whether you'll notice this. So for me, this was appearing pretty blue there. Uh,
Yeah. This the below thing. I mean, the inferior part, no? Inferior, middle
yes,
inferior.
yes,
Right.
yeah,
It's like
yeah,
a vein actually hanging vein.
yeah.
Shishir, Samir
Yeah.
here.
Hi.
Uh, what what I knew is there are some two horns of thymus.
Yeah,
So and
right.
just below that there would be some large vessels and
Wait.
brachiocephalic or
Correct,
denominates.
correct,
Yeah.
correct, correct, correct.
So
So it would
what
be
care
here.
would you take? What care you take because they are very rigid instruments. They go at a certain angle. So how
Huh.
will you try and take care that you don't damage them? Especially you want to do a
So,
total thymectomy taking out horns.
especially if you are doing a thymectomy for a myasthenia, then it's important that you clear everything, even the horn bit of it. The horn is easily pulled out. What happens is when you're dissecting from below, the best thing, can you see this vein here? Can you see my arrow going on the vein? So sometimes it is best that you delineate your vein first only, so that uh, it's otherwise there is nothing much. The anatomy is pretty clear as long as you're careful with your instruments, these rigid instruments. It's more of
It's
fear
like
that we are like you can see the horn here. We're trying to pull it out. Can you see this? It's at the root of the neck, but there is a whole
Yeah.
lot of thymus glands here. So if you go on pushing it out, it comes out nicely.
it's like you hold, Samir sir, you hold this with one instrument, you stabilize it with one instrument, and with the other instrument, you gently tease the horn out
Yeah.
with the camera. That is how
Now
you
you see
need
how
other
I've
vision.
just
Nothing is there.
Yeah, exactly. And
dissected this out here. Yeah. Can you
And
see
they
this?
go above the vein. They go above the
Yeah,
vein into the neck. So
yeah,
it is
yeah.
easier to identify the vein first and then go for the
Perfect,
horns,
perfect,
especially in
perfect.
myasthenia gravis. Yeah.
Yeah, 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 yeah.
Uh, would you be using harmonic always, or would you prefer Ligash or any other energy
So,
source?
so, so normally I use a hook
Yeah.
for all this. Uh, Harmonic, this was the first time I was using this Merrill harmonic. Pretty
Oh,
interesting. So, yeah, I loved it. Samir, you should buy one of these because you can take it anywhere you want in that bag which you travel with. You can
so
put it in
now
the back of
I'll
your
ask
bag.
Meryl now. I'll contact Meryl.
You can just put it in your rucksack bag and take it. That's the best part of this harmonic.
Sir, hook is Shishir sir can be using hook very comfortably. It is not to be displayed on national TV, and don't recommend it to your juniors. Shishir sir,
I know,
don't
I
do
know,
that.
I know.
Everyone is not
Yeah.
as good as you.
No,
Sir,
everybody, I think people would, I think it's a comfort level of what
it's a
you are
comfort level.
used to.
Harmonic
Yeah.
versus
But
Lagashore
harmonic,
versus
I
hook is
feel
all
is,
as per the
pretty safe compared
yeah
to
harmonic
any of
ligation
the,
hook whatever your comfort level and
yeah,
safety level one
correct,
yeah.
correct, 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 correct.
As
Uh,
long as everything is out without any damage and we are able
No,
to get the
absolutely.
entire thymic tissue out, phrenic to
Yeah,
phrenic, inlet to outlet.
yes.
yeah, but, yeah, if you are having a unilateral approach as what you're doing from left side, how do you
Right, sir.
safeguard the opposite side phrenic nerve?
No, 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 no.
How do you safeguard, sir?
So in this
Yeah,
case, we are
because
just removing the thymus gland. This is not because we are just removing the thymoma. But
oh,
from this side, you can approach a little bit. If you have a problem, of course, you can put another port there and see. And I think, yeah, that's sort of done here. Yeah, little bit of tissue. So initially, I thought this would be the vein. Uh, it looked like that, but anyway, the vein is pretty up. It's got good planes.
but what we are seeing is you are working with only one hand.
Yes, I've got two ports. One is on the other side, so it becomes one thing to hold and the other to.
Traction and counter traction. The
Yeah,
same
Yeah,
it
principle
helps.
from breast to thymus. It
Yeah,
still works the
everywhere,
same.
everywhere,
It
everywhere.
works everywhere.
And then you
rather
can
what I
just.
think, what I thought is usually this the thymus surgery simulates more of endocrine surgery where you require to maintain the capsule intact.
So the
Uh,
capsule is here. Can you see this?
Intact,
yeah,
sir.
Capsule is
yeah,
pretty
yeah, yeah,
intact.
yeah,
So
yeah,
the
yeah, yeah.
capsule
Intact,
capsule
sir.
is
It's
here.
intact.
Huh? I am here on the normal gland here. Huh?
Yeah.
So what I'm actually doing is I'm pulling it out. Huh? Yeah.
So it's a control kind of traction.
Yes.
Uh, did you have to remove any time part of pericardium while
No,
doing
no,
removing
no,
from?
no. I This was a
I have done that.
clear-cut case. But
Not this one, sir, but we've done that. I'm
yeah,
sure sir also must have done that
yeah, yeah,
in
yeah, yeah,
malignant
yeah.
thymomas.
Sometimes, usually, Samir, you will get a clear plane. Sometimes, if it is stuck, you might as well make a small opening and see, remove a piece of pericardium along with it.
But does
It
literature
makes your
support
life.
doing laparoscopy or thoracoscopy for thymic malignancies, or better to have a open approach
Look, the
with
clearance, the
good
clearance is
clearance?
pretty good. I'll tell you, the clearance is pretty good as far as the VATS is concerned. So there is no issue as to why you should not do it. There is no clear-cut studies which has compared these two datas that I'm aware of. Just a little bit of tissue there left. Can you see that? Yeah. Like Samir was doing, even I was bothered about whether, to keep the capsule intact. So that is why I was not even, I was not holding the thymus tissue. Because sometimes when you hold, you can burst the capsule. So I was being a little careful there. Yeah. Yeah. This looks like a major vessel, doesn't it?
Yeah.
It is not. But yeah, it can be.
Have you encountered some low placed thyroid at such instance, and how do you be able to differentiate if it's nearly adjacent to each other?
You won't. You won't be able to. You just remove a piece of it. Okay.
No,
In
but
fact,
at
I
time
feel
if
that
it
every time you do a central dissection of the neck, you invariably remove the piece of thymus from the neck.
oh,
Yeah. So the vein is pretty clear here. So
Seems to be one of the largest thymic veins or something like this.
yeah, it looks like that. So I put in a clip there. A little worried about it. Can you see that? Yeah. It looks like a pretty big vein, isn't it?
Definitely, sir.
Yeah. The funny part, it just looked like it. It was not. Although I put in a, yeah, but I can you see this? Yeah. Fine vein there. Yeah. So it looked very thick, but finally it was a small one there.
In patients with myasthenia, what we do is usually lift up the thymic tissue of this innominate, clearing most of the thymic, this innominate vein, and
Yeah,
then
yeah, yeah.
down to thymic tissue and thymic horns.
Correct. So in that, we remove all the fatty tissue right from all over the pericardium also. If you're doing it for myasthenia, we have done some interesting myasthenia cases. Myasthenia crisis.
Did you encounter any patient who have resected this phrenic and had post-operative issues in ventilation?
No, I did not. He was not even in the ICU. So.
So you are saying in invasive thymoma, and if you are removing the unilateral phrenic, usually there are no major post-op issues.
No, no, I don't get uh, good chest physiotherapy. Usually won't get. Small ooze are there. All this can be a pretty scary. Turned out okay. Samir, hello.
Yes, yes, yes.
Good. This is not live surgery, isn't it? Otherwise, you would have been, everybody would have been scared. What the hell is he doing? Karke?
No, no, it's not that way. But see, thoracoscopic
This
surgery has is quite lagging behind, but it's a quite interesting surgery personally.
it is. It is
Uh,
very interesting. I
if you
love
know your
it.
landmarks, if you know your landmarks, possibly you can get away without a large incision which goes across ribs with rib resections. So
Yeah,
I
you
think
see, the if you look at many a few years back, if you look at all the cardiac surgeons, they used to do a mid sternotomy for these patients. Now, VATS is pretty good, for this.
even I saw some video on YouTube of sub-xiphoid approach. It
Yeah,
looked for me quite interesting because they don't approach either side of the pleural cavity. They directly attack mediastinum. So
huh.
it was
So that
very
is your
good.
vein which I'm just clipping up. Can you see that? Yeah.
Yeah, yeah, yeah.
Uh, Dr. Shetty, yeah. I work in an institute where it's more or less neurological work. So we do get some benign thymomas, but more or less it is for myasthenia gravis, what we are doing
Yes.
thoracoscopic thymectomies. So in that
Yes.
also, I keep changing my this thing, but I prefer to go from right side most of the times to do
Yeah.
a
Yeah.
thoracoscopic thymectomy. That I usually
Correct.
prefer to. Yeah.
But
And
if
as
you
you
look
said,
at
yes, we
the
have to go. Yeah.
correct, if you look at the CT scans, then this is predominantly on the left side.
Exactly.
It
No,
make
no, no.
it
I'm just
it
talking about
wouldn't make any sense.
non-thymomatous myasthenia gravis.
Yeah.
Non-thymomatous
Yeah.
myasthenia gravis.
I
Yes, yes.
agree. So
Thymomatous, of
that is
course,
very
wherever
clear
the
that
thymoma is going, you come from that side. Yes.
yeah. So this was pretty clear that you had to just go from here and get it out. So yeah. So this piece of tissue is nicely hanging. I think just pluck it out from there. But the best part, I'll tell you that what I was initially thinking that this is probably the vein is not. It's actually a thymus gland. I'll show you. I went ahead and after I removed this, I went and cleared that area also.
So in myasthenia, usually the tendency is to uh, poke through that mediastinal pleura and have a look at the opposite phrase. So
Yes, yes.
So do you ever try Subzifoid?
I have never done. I have never done. I keep hearing about people who are doing, and I'm sure they're happy. The approach looks interesting. Yeah,
It's interesting, sir, but only thing is you need a very good camera person. Otherwise, you are always struggling with the camera person in a Subzifoid.
yeah, yeah.
And I guess you
I
need
think this.
longer instruments also for that.
Sorry?
Longer than that. I think you need longer instruments also for that. I guess that's what I've heard. I mean, longer
No, no, no,
instruments
no,
for that.
no. If you have a uniportal VATS instrument set,
Yeah,
you can
yeah.
use that.
That
That should
does
do
right.
good.
Okay.
That should do good. Yeah.
So this is what I think you was talking about, that the tumor would start rotating. Samir,
Yes, yes, Shishir.
I think this is as good as live, isn't it?
Yeah. So this is what we want. Basically, we require to understand and give a good concept of what
Because the
steps.
problems that you face in smaller things, like here,
Yeah.
the confusion, all that is avoided.
What is this?
This is thymus tissue only, and the few lymph nodes around there, surprisingly.
Best, best
All
part of the
right.
virtual live is that surgeon is also more relaxed and he's able to answer all the questions at at that given moment itself. That's the greatest advantage.
Yeah, that's it. I'm done. If you want, I can show you what I went ahead and removed these tissues also. But as far as the thymoma was concerned, it is done. I think I'll take it a little
So would
fast
you
forward so that we. Yeah, yeah.
so
Go
would you
ahead.
back the specimen and remove?
Yeah, yeah, yeah. I bagged the specimen and removed.
Now, what up till now, what problems I've encountered in such things is usually when you drop the specimen, it goes in some on the lateral aspect from where our ports are going to come. So, how do you tackle
I know.
that? Because then, with
So,
laparoscope
so
going in
chest
reaching
is
that acute area
no,
nearby becomes difficult.
no. I'll tell you, chest is a smaller area, Samir. So it is easier. Abdomen can be crazy, right? Yeah.
We don't have so much place to put so much CO2 inside. So
Yeah.
No,
So
but
you
usually for
usually
thorax, no,
find it.
yeah, but thorax, the ports are quite rigid. Abdomen, it's usually pliable. So you can at least bend ports and still maneuver yourself to some angles. In a
Uh,
thorax, if your port placement goes wrong, you are looking for a larger trouble for yourself.
So one more thing was this was single lung ventilation.
DLT.
So we had DLT. So we had a good anesthetist, but somewhere in between, suddenly uh, they tried to correct a good thing, and then the lung started expanding. Uh, but they corrected it. So meanwhile, we
So
took our
do they
time
put
cleaning up
DLT or they use the bronchial blocker?
blockers.
Ramkaran sir, what do you prefer, DLTs or
Sir,
blockers?
DLT is preferable wherever it is available. I think it must be some not expensive.
comfort level.
Most of the anesthetists prefer using this DLT. Manju must be aware that what we saw in Sangai Panoli Hospital, they are using this DLT which have this video at the tip of the DLT. So you have a exact
Can
idea
you see
of the
me put my
location.
finger there?
Yeah,
Huh?
yeah.
This is the advantage. So I remove the rest of the tissues also. Just think I can just fast forward this.
Sir, about life surgery in thoracic surgery, especially lobectomy in benign diseases, there are many difficult surgeries, time-consuming surgery, many times conversions. I think it's a better idea to have present these videos rather than we can have live surgeries, especially in benign diseases.
Yeah.
Uh, when you're doing from one side, how would you know that you have not opened the contralateral pleura?
You can see the lung from this side. Like you can see this. If you have opened the lung, you will see the
Lung.
lung tissue from here. Yeah. Look at here. This is the pleura here. There's a nice space. You can't see the lung on that side.
Okay.
So this is the remaining thymus gland. Huh? So I went and removed that also. Can you see this?
Yeah, yeah.
This is a normal thymus gland. Yeah. So my one surgery was done. So it's just a matter of removing this.
So would you approach the same from the same side, or would you try and go and
Same
control
side.
that side?
Same side. I could remove it from the same side. No issues. Because it's a normal gland. Normal gland is pretty easier. Can you see the vein here? Yeah, this one.
Yeah, yeah.
So when you do this, your innominates, the brachiocephalic, everything will go down. This is the best way to do it. So initially we had this discussion that in normal when if you're doing for myasthenia, the gland is pretty normal size. Then it is easier to create a plane from down and lift everything up. Yeah, can you see this?
Hmm.
Yeah, and then with the traction, counter traction, I think you can. The thymus gland is a pretty forgiving gland. It's a very nice surgery to do. In fact, I feel for beginners, thoracoscopy, before they try thinking that empyema is easier, they should do thymomas rather than empymas. Huh?
Sir,
Any comment on
what
this?
would be, sir, what would be advisable would be taking the this all of the thymus and thymoma block. So
Yeah. Can you see this? Yeah. Now I'm going into the root of the neck here. Huh?
Hmm.
Yeah, here.
Yeah,
Here I'm getting the cornu properly now. Huh?
yeah.
Yeah. And it's lifted off from here.
Mm-hmm.
You have to be very patient. Uh, of course, this doesn't look like I've had any patience in this, but in chest, it's better to exercise patience. Yeah. Uh, Samir is laughing of people who know me. I think, yeah.
It looks like you just want to complete the thymectomy as early as possible.
Because you see, what happened was I removed the thymoma, and then I was thinking, why I am doing this? Why am I removing this rest of the gland? Because if you actually tease it, if you're doing say open surgery, and if you hold it and tease it, this will actually come out so very nicely. Huh?
Yeah,
Yeah, I think it came out also. Yeah, look
already
at
out.
it. Huh? Yeah, yeah.
Yeah, already. So would you be leaving some ICD or some mediastinal drain there?
We put an ICD. Yeah, we put an ICD. It's just cleaning and stuff.
But would that ICD go in only pleura or go into mediastinum?
So
One actually.
only one ICD. People put two ICDs. I just put one ICD. Keep it in the pleura and come out. Yes, thank you. This is that specimen which Samir was talking about that it may be hidden. Believe me, Samir, it's easier to pick it up from here than somewhere in the abdomen. Yeah. Thank you. Thank you.
Thank you, Shishir.
So, Shishir,
Yeah,
would
yeah.
you widen that port?
Thank you.
Yes, I
The
widened
which
that port, put in a plastic, and just I took the mid clavicular segment to remove it.
See your direction. When you taking it,
Yeah.
it will go parallel to this. This is the line.
How long you keep the ICD?
One day.
One day. Okay.
Yeah.
uh, any chance that any injuries to the phrenic nerve, can you predict that I understand you have gone away from it, but any chance that can you predict that you may have caused some thermal injuries nearby? Because finally you're supposed to go anterior to the phrenic nerve.
Post op, right? Uh, luckily, we are using a harmonic, but we are quite away from the phrenic. Phrenic is pretty sturdy that way, so it shouldn't be a problem. Hi, Priya.
Yeah,
I
but
can see you there.
whatever harmonic also gives some lateral spread, right? The active blade also
It does.
can
It
have
does.
some.
It does. It does. So post op, if you have issues, then you can understand that you have really injured the nerve. Yeah. Introp, I don't think you
And
can make out.
how would you follow up this patient?
These patients, just a regular X-ray post op, day two, in 48 hours, patient gets discharged, and then maybe 3 monthly X-ray chest and regular follow up. Most of them they don't follow up only. So yeah.
Do you give intercostal nerve blocks intraoperatively? Intercostal nerve blocks.
Yeah, yeah, we do that. Anesthetists make you do that. Yeah.
Paravertebral block
The
also actually works very well nowadays. The serratus anterior
Yes,
blocks or
yes.
paravertebral blocks, if they are good with that, then we recommend that. Intercostal blocks are, uh, if they are
Temporary.
not comfortable with paravertebral, then we give intercostal. Otherwise, if they are good with paravertebral or serratus anterior block, that works much better than intercostal block. So that works better.
So this came as a WHO type B1 thymoma. So
So, any questions on the chat box by viewers? I doubt nothing has come yet. So, any questions, moderators? Any last word,
Only thing,
Dr. Ramkar? Huh.
sir, I do my cases with myasthenia, not malignant. So our approach is slightly difficult. We try to take this fade from the epiphrenic area up to the neck and try
everything.
to take it out and block. And we always poke through the mediastinal flora through the opposite side, having a look at the opposite phrenic, and then lift up the from the illuminate and then taking out the horn. That is slightly.
Perfect.
Dr. Priya?
And nothing beyond the master.
That's a safe word. See, there are two Shaktis here, and I'm a target in between. You can see me, so you know how they're handling me. So, Shishir,
Thank you.
I'd like to thank you from bottom of my heart for at least last moment coming in, pitching in. Uh, uh, I would like to thank Dr. Ramkaran, Dr. Priya. Acha, there is one question. What are expected complications after surgery? शिशिर किसी गायब हो गया.
नहीं हूँ मैं हूँ मैं.
हाँ, नहीं उधर दिखा नहीं इसलिए डर गया. What are somebody has what are expected? What are no, he's in hurry. That's why. What are expected complications after this surgery?
So the main complication that everybody worried is bleeding. Other than that, you wouldn't expect anything else here.
by accidental you open the pericardium, would it have? Would you have to resuture it? You have to do
No,
anything to
no,
it?
no. We just leave it. We just leave
Nothing.
it alone.
So
Nothing.
is your anesthetist spotted that you have opened the pericardium? Because
No, they
I,
won't
as
even
a
come
surgeon,
to
I may
know.
not understand.
They won't come to know.
They
They
won't come
won't
to
come
know.
to know also you open. So if you tell them that, you create a problem. So look, there is this rare complication that if you make a very big pericardial window, there is this chances of a hernia. Ramkaran, I think you will have more experience about this. Uh, I have yet to see one hernia, but yeah.
So
So
Not
commonest would be
experience.
as routine, maybe bleeding, but
yeah, that's
intraoperative. But you should try and intraoperative try and
Innominate vein injury,
inject.
yeah.
vein
Bleeding is
stenting,
the only thing that
sending
you are
nerve.
really worried about, and it can be disastrous. Huh? You may not have the time to open up. You see, this thymoma is pretty close to the pulmonary vein. Normally, it is not. Normally, it is nicely placed above. If it is on the right, SVC is a issue, but otherwise, it's pretty straightforward.
Any more questions? No, I
Actually,
don't.
last month, Dr. Ramkaran had done a CME on robotic thymectomy. It was
Oh,
well
wonderful.
received, and yeah, it was endorsed by Amasi as well. It was in Jodhpur.
Yes, sir. So
Huh.
I am doing mainly from the left side approach, and you already said he's doing a subzipod approach. It's slightly time
Huh.
consuming, but I think subzipod
Early.
approach is the approach which is for thoracic surgery.
Hmm. I have not done a uniportal thymus, so I wouldn't have much experience about that. Manjunath, have you tried? You can share.
Yes,
Uh,
sir. We have done a few cases where it's a small thymoma, not much, like no chemotherapy or anything. We do uniportal. Not very difficult, sir. Only thing is you might have to struggle a little bit if you come from the right side to see the left phrenic. That part is there.
so that can be a problem, right? Yeah.
Yes, sir. Yes,
Yes.
definitely, sir.
Unlike a lower lobectomy or upper lobectomy, probably this would be a little tougher
Yes, sir.
thymoma if it is a little bigger.
Yes, sir.
But I think to each his own, as long as you are safe in what you're doing.
Exactly.
Thank you.
Thank you very much,
Thank
sir.
you,
Very nice
Roshan.
video, sir.
So
Roshan, nice
Thank you,
to see
sir.
you, Roshan. Thank you,
Yeah,
Manjunath,
nice to see
Priya.
you, Shishir, after a long
Thanks,
time.
Amir.
Yeah,
हाँ,
Yeah.
thank
So
you, thank you.
let me at least official thank you.
अरे मैं ही
Let,
पहले था क्यों बोलने
so let me first thank the moderators, Dr. Priya, Dr. Ramkaran, Dr. Manjunath, and Dr. Sanjay
Thank you,
Kolte
sir.
for spending time with us and moderating
Thank
an
you.
important session from an important oncosurgeon.
Oh,
Let me thank Dr. Shishir Shetty who could actually devote some important time. Otherwise, he may not be available most of the times. But at last, at one phone call, he just said yes, and he presented this video. So my aim is usually try and put some surgeries which are not done by most of the surgeons, so that people get interested in this, because this is one field where I think most of the laparoscopic surgeons do not venture into. And if possibly your landmarks are right, thoracoscopic surgery would be very very safe, and you try and take out without a large incision, rather rib cutting incisions, without doing rib excision, so it will be much painless. So thank you, Dr. Shishir. I would like to thank
thanks.
Dr. Roshan Shetty, who I see is with some swimming pool behind him. So still with
That's
us
a
in
virtual
academic,
background, Samir.
yeah. Oh, but whatever in the academic forum, he's still there. Let me thank my Amasi family and more or less Merrill to support this entire event of us, which happens every third Thursday of a month. Let's hope we get you with another good event, maybe on the third Thursday of November. We'll keep you posted. Uh, till then, I
Thank you, sir.
think I thank everyone, and let's call it a day. Dr.
Thank you.
Roshan,
Thank
you
you.
want to
Thank you.
say anything?
Thank you.
Bye. Bye.
Nothing much.
Thank you. Thank you so
Samir.
much. Yeah. Thank you.
Thank you all. Thank
Thank
you.
you, Samir. Thank you.
Off.
समीर भाई अगला वाला थोड़ा जल्दी करना पड़ेगा मार्केटिंग थोड़ा